Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare and moderator for today's program. The program will begin with a presentation followed by a question and answer session after the presentation. You could submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of today's program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Lisa Rock. Lisa serves as President of National Medical Billing Services, one of the largest ASC billing companies in the country. Lisa is a seasoned healthcare management veteran with over 25 years' experience in the industry. Her wide-ranging background consists of Director of Training and Education for Mid-Atlantic Medical Services, Inc. of 7 years, and Vice President of Business Office Operations for an ASC development and management company, 2 years. She has also managed private practices in the specialties of orthopedics, rectal surgery, cardiology, and anesthesia. Lisa's unique knowledge of healthcare management has provided NMBS's clients with the tools and information they need to most effectively run their facilities in the highly fluctuating business of medical billing and compliance. Our next presenter is Jessica Edmiston. She is the Director of Coding for National Medical Billing Services. Jessica is a certified professional coder and has been coding for the surgery centers across the country for nearly 10 years. In addition, she has performed numerous coding audits for ASCs across the country, identifying compliance issues and areas of missed revenue. She leads an outstanding team of the most experienced and skilled ASC coders in the country. She is nationally renowned for her coding expertise, as she is regularly requested to speak at large ASC conferences and has written numerous articles in various trade publications. She also developed a training program for new coders and also ensures that she and her team focus on getting extensive continuing education in ASC coding to ensure that all NMBS coders stay current with all of the trends and changes in the industry. Jessica has a bachelor's in science and education from the University of Missouri, St. Louis. Our third presenter is Tamara Wagner. She is Vice President Coding of National Medical Billing Services. Tamara holds a BS in biology from St. Louis University and is a certified professional coder. She has over 9 years of ASC coding experience, specializing in orthopedics, podiatry, and pain management. Tamara has been one of NMBS's lead auditors for over 5 years, helping to identify compliance issues and missed revenue. It is now my pleasure to turn the floor over to Lisa Rock to begin today's presentation. Lisa?
Thank you, Kathy. Good afternoon, all. We have a lot of material to cover, so I'm going to get right to it. We are going to break this presentation into 3 sections. The first, we will be looking at documentation challenges and suggestions on how to remedy those. Secondly, we're going to look at coding issues and edit systems. And third, we're going to look at specialty-specific coding scenarios. Next slide, please. And next slide, please. One of the most frustrating challenges right now for coders is the template issue with EHR, EMR systems. I know that this operative note is hard to read, but if you look at the pre-op diagnosis, we have a bilateral knee, degenerative joint disease. We have, if you skip down a few lines, a procedure of left hip injection. And then when you go to the body of the op note, you see that the surgeon performed a hip injection and resolution of pain on the left wrist. This is a clear template issue and a surgeon rushing through notes. This is problematic, and I would like to say that it is not unique. Sometimes surgeons are using templates for procedures other than what they're doing because they're not available. In this case, free texting doesn't always work. You should always have a fallback in the old-fashioned dictation for scenarios such as this. You can't code off of the operative report with discrepancies as blatant as this, and you can't guess. So our suggestion is to have a combination. Really look at your template to make sure that you have a template or working on a template for all of your cases, and if not, have a fallback for the surgeon to dictate the good old-fashioned way. Next slide, please. If the dictation is in question, we suggest working with the surgeon in this fashion, and I'm going to let Jess explain what this form is. I'm sure this is pretty common, but for those of you that don't know what this is, we're going to explain what it is and how it's used.
Good afternoon, everyone. This is an MD query form that we have created, and I'm sure many of you use something similar to this. Basically, this is just a form that we phrase the question that we have about the dictation. In this particular case, it was a knee procedure, and the surgeon failed to mention what compartment he would be doing a synovectomy in. So we've listed the 3 different compartments and asked him to simply check mark which compartment or compartments that he was doing the synovectomy procedure in. And once he checks this off and signs it and sends it to us, we make it a part of the medical record, and we can get our claim out the door.
This is nice too because it's difficult to get the surgeon sometimes to redictate or dictate an addendum. And this is easy. When they come into the surgery center, you put it in front of them, and they X marks the spot, sign it, and you scan it into your EHR system or simply file it into your hard copy medical record, and this works just fine. And it is the less, I would say, intrusive way of dealing with them. They don't seem to mind this so much, do they, Jess?
No. I mean, if you have a difficult surgeon, he's going to be difficult either way. But this
no, there's no such thing as a difficult surgeon. Come on.
This seems to be the least amount of work for them. So.
Okay. Next slide, please. We're going to talk a little bit about incomplete documentation. We do a lot of audits across the country, and we see a lot of guessing at what the surgeon did. And of course, we all know that assumption coding is not allowed in this business, but we see it all the time. And incomplete documentation isn't necessarily just missing documentation. It's looking at inconsistencies in the operative report, like I just mentioned a couple of slides ago. It is important that the procedure headings and the actual description of what was performed matches. And Jess, would you like to give a couple of examples of when you see this most? I know you see a lot of it in pain management.
Right.
So why don't you give an example of that?
A lot of times if they're doing multiple procedures, they will list, their procedure headings will state that they're going to do facet injection, L4, L5, left and right, and then they'll have a second procedure listed. They might be doing a hip injection. But when you get down to the detailed description, you only see the facet injections documented. You cannot code that hip injection unless you go back to them and clarify. Like Lisa mentioned earlier, it could be a template issue. He was pulling things and didn't really do a hip injection. So you can't assume just because he has it in the procedure heading that it was performed. And the blanks in medical records, you may or may not see this depending on how good your dictation service is, but these are literally blanks that either the transcriptionist doesn't understand what the doctor is saying, so they leave it blank. But one or two here and there, if it's not in an important part of the record, is okay. But we've seen them where there's 20 blanks in one record. You've got to go back and ask them to redictate or fill in the blanks. And then we recommend waiting for path reports when necessary, and request history and physicals if you need additional information to get your case coded correctly.
I'm going through the sort of basic information rather quickly, and we'll spend more time on sort of the meatier part of this presentation, like the next slide. So if we could go to the next slide, please. All right, this is a tough one. Edit systems. It's so important for you to choose a policy for your own center on which edit system or systems you're going to use as part of your business office operation compliance policy. So I personally choose to use NCCI edits across the board, with workers' comp being the exception. I'm finding very little differences today between, or very few differences between McKesson's claim check now and with respect to ASCs and the NCCI edit system. However, you need to know that there are several edit systems out there besides those two that I just mentioned. Sometimes an edit system is a doctor making a decision on something that he feels or she feels is incidental to the primary procedure. And using a standard policy of one edit system across the board will help you in your appeals. And you can go back to that carrier and state, look, we use a federally recognized edit system to code our claims going out the door. What are you using? It's a very good argument that goes all the way up to the insurance commissioner that you can win if necessary. So first is identify what edit system or systems you're using. If you pick and choose, there's nothing wrong with that either. I've just found that you have more mistakes when you have multiple edit systems that the coders are required to refer to before the claim goes out the door. And also, in light of HIPAA's administrative simplification, it doesn't make any sense to me to operate multiple edit systems on the front end if it's not necessary. But again, that's a personal decision. Let's talk about what if the dictation doesn't support medical necessity? All right, so we have the edit system, the claims going out the door, and we see, wow, the doctor used an ICD-9 code that is not medically necessary. That is definitely problematic, and I'll tell you why. When you're getting clarification using an MD query form for incomplete documentation, that's one thing. To lead a doctor to choose a code, ICD or CPT, that's payable is quite another, and you're not allowed to do that. So you have to be very careful. So for example, I've printed off my LCDs. I'm looking at a list of approved diagnoses for medical necessity, and I show the doctor, look, you picked a code that doesn't pay. Can you pick one of these? You can't do that. If you're missing a diagnosis code and you need him or her to simply provide it to you, you can't go back to the surgeon and ask or tell him that this one pays and this one doesn't, which one do you want? You have to be very careful not to lead the doctor into picking something that's reimbursable or reimbursed at a higher level. So what's the difference between leading and educating providers? That is a very good question, and it's difficult sometimes. So you have to stay on top of all of your local carrier determinations, your national carrier determinations, and you sit down with the doc, give them the list. That's fine. Educate them on what's approved and what's not. And Tamara's going to go into a couple of examples of what we're talking about with the LCDs and how she goes about training surgeons without leading. So I am going to ask that we go to slide 9 and then turn over medical policy and LCDs over to Tamara.
Good afternoon. As Lisa said, the next 3 slides, we've given examples of a couple specific carrier medical policies and Medicare LCD. What we've done on these 3 slides is just given key points that the providers and coders need to be aware of from these carriers. It's very important that their documentation is following the specific carrier guidelines and meeting medical necessity in order for their claims to get paid. The examples here are for pain management and GI, and we look at these LCDs and carrier policies all the time in coding because they have very specific guidelines that in order to get the claim paid and meet medical necessity, these have to be followed. For example, if you're seeing claims being denied, you want to go back and check your LCDs and your policies. It may just be a fact that your diagnosis code reported is not meeting medical necessity per the guidelines. And therefore, you need to really be aware of what diagnosis codes meet medical necessity for each procedure. And if you have any question with that, you do need to speak with your physicians and make sure that you educate them according to the policies and the LCDs.
Next page. Next slide, please, Kathy.
Couple slides.
Why don't you go through some of the specifics on these? Okay.
Can we go back just a slide, please?
To what number slide?
Slide number 9.
Oh, they're not right. Right there? Medicare?
Yeah.
Okay, that's good.
One of them we have an example because we see this all the time with Medicare is a diagnostic colonoscopy, and there are specific situations where you know, a diagnostic colonoscopy is warranted. There's unexplained iron deficiency anemia. There has to be evaluation within 6 months of the removal of sessile polyps to determine and document total excision. If an evaluation indicates there's a residual polyp present, excision should be done with repeat colonoscopy within 6 months. After evidence of total excision without return of the polyp, you need to repeat the colonoscopy yearly. The second point is evaluation at 1- and 4-year intervals after resection of multiple or large polyps. Subsequent surveillance intervals may then be increased to every 5 years. Evaluation in 1 year after the removal of multiple polyps and adenomas. If the examination proves negative, then you repeat in 3 years. After 1 negative 3-year follow exam, repeat exam every 5 years. And then it's also really important to know what specific diagnosis codes meet and support medical necessity. And this is really important that the doctors have this documented correctly, because if you bring a patient back in before these time frames are met, then you're going to see claim denial, because they're going to look at it and say that, you know, they're coming in too soon. It's not necessary for them to get the colonoscopy after such a short period of time. So it is very important as a coder and as a provider to know this information.
So again, these LCDs change by carrier, sometimes every couple of months. And this is a very difficult thing to manage with respect to your claims getting paid. We see over and over and over again schedulers booking cases and not following these LCDs on the front end. So I think, too, Tamara, it would be a good idea to train the coder, pardon me, the scheduler as well on these LCDs, so they understand that if someone had a certain procedure and they need to wait a certain period of time for reimbursement, that you're not going to be treating patients and getting claims denied.
Yes, and also I think as far as too when they're getting authorization and knowing when to bring these patients back in. You know, if a time frame hasn't been met, then perhaps you shouldn't be bringing them back in and seeing them again.
And there it goes back to practicing medicine or following these carrier determinations. It's just so difficult. We understand that. And again, this is a challenge for coders because you have these LCDs at your fingertips, especially if you have aren't these provided through coding software systems, Tamara?
Yes, they are.
Through most of them?
Yes.
So if you're currently utilizing the, the Curo, the 3M, the TrueCode, this is where you're going to get the information. Otherwise, if someone listening is not subscribing to coding software, how can they get these LCDs?
You can always go out to the internet and Google a carrier or Medicare, and you can easily find the LCDs out there on the internet under each carrier.
Okay. All right. Let's go to the next slide, please. Missing information and the reconciliation process. This is tough too. We recommend tracking your missing information or incomplete information on some type of Excel spreadsheet and staying on top of that and not closing that particular day's file out until you have every single medical record for every performed case on that particular day. And also, the date of service should be on this spreadsheet, as well as guesstimated net revenue or gross, depending on how you operate your business, so that each week as it begins to build, you can give your management or surgeons an idea of the dollar amount that's not being booked immediately, because this will affect your aging report, by the way. And so for those financial managers, it's important to tie these two pieces together, very important. Also, you have timely filing issues, and this is a very good way to track your timely filing issues. Again, if you have a contract that gives you 30, 60, 90 days and the missing info is not clarified, you can't send the claim out. It's not correct. Nor can you send your claim out on nurse's notes. The OIG is very clear that you must have physician notes, not nurse's notes, to code from. So to track this and tie it to the schedule is extremely important for a coder. Approaching surgeons, I wish I had the answer for you on this one, but I don't. If I did, I'd probably be very rich. But I can't help you with that. I put it up there because it's an issue. It's the one answer that we don't have. But it is important to approach them if the dictation becomes a problem, if it is not complete, or any other issue. Again, this missing information report can also contain claims that are waiting for path reports, that are waiting for invoices, for implants. It's a good way to track all of your possible charges that you're holding. So with that, I'm going to let Jess explain the unbilled report and why it's so important to reconcile the unbilled report out of the system, which is different than the missing information report, back to your schedule. So why don't you go ahead, Jess, with the unbilled.
Yeah, the unbilled report should be ran at the end of the month. I know everyone's busy at the end of the month, but maybe wait a week into the new month so you can account for all of your charges for that prior month. You'll have given the charge posters and your claims department time to get the bills out the door, but you want to run this report, and your software system should have this, and I know that some do not, but most of them do. You want to run this report to capture anything that has been scheduled and not charge posted, and also not charge posted but not billed. So it's a check and balance system for everything done in that month. And if there are items on this report, it should match up to your missing info, because those are the items you're holding. There have been cases where we've gone to run our reports, and cases pop up that weren't originally on the schedule. And that's a big problem. You don't want anything to be scheduled 2 to 3 days after the date of service.
We do see this a lot, by the way.
We do. And this is how you're going to catch it.
And you're going to, yeah, right.
This is really the only way to catch it. And if they, if it is scheduled a month after the case, you may never.
That's crazy, but we've seen it.
So,
okay, So I think to Tamara, if you could also explain a little hiccup with the unbilled reports as well.
Right. We have a particular management billing system that we use that they actually enter encounters, and where we run into problems in running the unbilled report is the front desk will enter duplicate or unbillable encounters, and you have to have a system where your front desk knows that they should only be entering one encounter per procedure. And if they do enter a duplicate encounter, they want to make sure that they cancel that out of the system. Unfortunately, when you have unbillable encounters on your unbilled report, it affects the problem for your accounting system trying to track accurate case counts and revenue. So we do see that as well. So you want to make sure that your front desk is accurately trained on entering cases or encounters, whatever the system calls it. We have cases and encounters in some of the software systems that we use.
Okay, thank you, Tamara. Next slide, please. I spoke earlier about whether or not you're using NCCI or National Correct Coding Initiatives across the board. And I think it's important to come up with a policy and also know which carriers are using it and how to handle workers' comp. It's handled different. Workers' comp is different just about in every state. Most do not use an edit system at all, and they like you to bill out full gross charges, all procedures all the way down, but really you need to check with your comp carrier in your own particular state. And then how do edit systems affect cash? Well, of course, it's a bundling issue, so I think that's self-explanatory for everyone on board. If you're gonna use an edit system, you are canceling out procedures that may pay for carriers that do not use an edit system. And again, you just need to look at your own facility and determine what the best policy is. But the point is to have one. Next slide, please. I've talked about claims matching for years, and it's important to know for coders that the way, and I worked for a carrier for 7 years, and I can tell you that from a carrier's point of view, the professional claim and the facility claim should match. It's the same surgery. Oftentimes they don't match because you have different coders. And it's difficult to match those claims out with different coders prior to the claim going out the door. So I think, you know, for your big ticket items, I would definitely call the administrator or the coder for the surgeon's office and make sure that you're on the same page with those larger claims. And then the longer you work together, I think you'll be able to vet out any differences. And the point is to have a really good relationship with the surgeon's office to make sure that you're coding those surgeries out in the same manner. Now, in the event that you don't or you haven't, what carriers will typically do is retrospectively review the claims, sometimes prospectively. Sometimes they will suspend a claim on the facility side and wait for the surgeon's claim and then match themselves. But most carriers will do a retrospective review and do what's called negative balance invoicing. I'm sure you all know what that is, and that's a take back. They're going to take back the difference in the two claims. So if you're coding it correctly, that's fine. It may be adjudicated and paid in a very different way than you coded it, and your cash poster has to be the one to spot it. And the way some of these EOBs come in, it's very difficult to see that. They might throw everything on one line and you can't tell. So you really have to watch this carefully, and with the negative balance invoicing, always look at the reason why, and sometimes that's hard too because they don't tell you why, they just take from future payments. But look at why, look at the coding, go back to the surgeon, make sure they match, and then do an appeal. That's the best way to handle claims matching. If it happens prospectively, when you're calling on an overdue claim or an outstanding claim, then you need to know that it may be hung up, it may be suspended due to this, and 100 other reasons, but this is one of them. Okay, next slide. All right, Jessica is going to get into some specific coding scenarios, starting with a screening colonoscopy.
Yeah, and these, some of these have to do, they're tough because they have to do with documentation issues, and some of them are just tough coding scenarios altogether. But this particular one is a documentation issue that we see commonly with GI coding. Screening colonoscopies. We are seeing from multiple physicians and multiple systems, we are seeing under indications screening listed, which is fine. And you may see history of polyps or family history of cancer. Those are all fine. But we're also seeing other indications such as rectal bleeding or constipation. And when you see those with the screening, you need to go back to them and clarify what was the true reason for this visit. Was it a screening or did the patient have symptoms? You know, you can look in the H&P. Sometimes you'll get more information from there. But if that doesn't help you, you'll need to go back and ask them. And the next slide is an example of one of these op notes. And I know, again, it's hard to read, but under indications we have change in bowel habits and we also have screening. So we would take this back and ask the surgeon to clarify. Okay. Tamara is going to discuss the next slide.
Regarding bunionectomies, coding bunionectomy procedures can create challenges for coders since these procedures are diagnosis-driven. And with that being said, we see many times, for example, a common situation where the doctor will be documenting a diagnosis of hallux rigidus, and then he's going on to perform what he's calling a Keller arthroplasty with an implant. And the doctor wants to bill out CPT code 28293, which is a correction for hallux valgus, bunion, resection of a joint with implant. And actually, we just had this question posed to the AMA, and they have come out again confirming that the only way that you can use this 28293 code is if there is a current bunion or a history of a bunion, irregardless if hallux valgus is present or not. So in this situation, if they're just correcting the hallux rigidus situation with an implant, you would have to default to an unlisted code of 28899 if there is no bunion diagnosis along with the hallux rigidus. And once again, this is a good example of going back to your provider and educating him or her on the coding guidelines for a bunionectomy procedure such as this. Next slide, please. This too is just an example of an op report with the hallux rigidus correction. Next slide, please. Another area that poses challenges for coders is pain management, and we've given just a couple examples here. The first one being the transforaminal injections, which also can be called selective nerve root blocks, and these are codes 64479 through 64483. And just to differentiate, the transforaminal injections are reported per facet joint level. So if the doctor is saying he's doing a transforaminal injection on the right lumbar, just one level, L4 to L5, you would report 64483 with a right modifier. And then if he is doing a selective nerve root block, but he's saying that he's doing it for the L3, L4, L5, those are actually reported per nerve. So if the doctor is stating he's doing the selective nerve root block and he's documenting 3 nerves, you would be able to report for 3 levels. So if it's on the right side lumbar, you would have a 64483 right, a 64484 right, and then an additional 64484 with a 59 modifier and the right modifier as well. And then the second example are the new RFA codes for 2012. The old codes 64622 through 64627 have been deleted as of 2011. And prior to 2012, you were able to report these procedures per nerve. And now as of 1/1/2012, you can only report these per the facet joint. So if the doctor is still documenting them per nerve and he documents 4 nerves, you would really only be able to report 3 facet joints being ablated. So that's the change there. It's going to change the revenue because you can only report per facet joint, not the nerve. Next slide, please.
One of the most common query forms that we have to send back to surgeons has to do with the distal radius fractures. And prior to 2007, we had one code for an open treatment, so it really wasn't a problem. But in 2007, we got 3 new codes, and they're very specific. So if he documents a distal radial fracture, you'll need to ask, and he doesn't state these things, you'll need to go back and ask if it was extra-articular or intra-articular. And if intra-articular, you'll need to know how many fracture fragments were fixated because your code choice depends on these things. So we commonly are going back to the surgeon with these questions, and usually after a couple queries, they'll start documenting the necessary information. And the next slide is an example of one of these op notes where, you know, it doesn't state intra or extra-articular, and it doesn't document the number of fracture fragments. Okay, the next slide. Sinus procedures can be very tricky. You're dealing with a lot of procedures in one op note. And when they move from sinus to sinus, it's sometimes unclear as to where they are. Some of the these are just some common issues that we go back to the surgeon to clarify. If they just state they're doing an ethmoidectomy, you need to go back and ask, was it partial or total, anterior or posterior? With the turbinates, you need to know which turbinate they're performing work on. Are they working on the inferior, the middle, or the superior turbinate? And what technique are they using? Are they doing ablation? Are they doing a submucous resection? If they just state turbinectomy and they don't tell you which turbinate, you need to go back and ask them. With the sinuses, we know that there are different codes if they remove tissue. So commonly we'll see in the procedure heading maxillary enterostomy with tissue removal. But when you go to the procedure details, there's no mention of tissue being removed. So this is something you can't assume they remove the tissue. You need to go back and ask them. And the next page is just an example of a turbinectomy where they don't tell you which turbinate. So we would recommend going back to your surgeon and asking them to clarify. And the next slide.
Coding for lesion excisions caused a lot of challenges, basically because the documentation is not as accurate as it should be. Many times what we see, the surgeons leave out the size of the lesion, and sometimes they don't even go into detail as far as the depth of where they're removing this mass from. So that's 2 things with lesion excisions that are absolutely important to have documented, depth and size. And as we know as coders, in 2010 they added more excision codes based on the size. So if your physician is leaving the size out and your facility tells you, well, go ahead and use the path report, you may be leaving money on the table, because we know when a lesion is removed, it may shrink. You know, it's just not the most accurate way to code for the size of a lesion. We would really like, in the best situation for the documentation that the physician provides, to have that in the op note.
Can I interrupt for a second? Sure. So if you go back to the surgeon and you ask him or her what the size of the lesion is and they answer you with olive, that's probably not going to cut it either, right, Tamara? The size of an olive?
Yes, we don't want any size of an olive. We want the actual.
Well, there are too many. I mean,
right.
green, black,
right.
stuff with pimento.
Right. And another situation with lesion excisions too is you want to make sure that if there's multiple lesions that the physician is documenting that he's excising through separate incisions in order to bill that accurately. If he's only reporting one incision or in removing 3 lesions, you would only report 1 actual code. But if there's 3 lesions and he's doing 3 separate incisions, then it warrants reporting 3 separate codes. Next slide. The next slide is just an example of a couple of different masses being removed. Next slide, please.
Okay, I know this one is hot, hot, hot. To bill or not to bill for the pain block. I wish I could tell you that this was an easy answer. This has been an issue for as long as I've been coding and billing, which is almost 30 years. And all I can do is provide you Medicare's definition and their policy. And they are very clear, and here it is. If you are the surgeon performing an operative procedure, you can't bill for the pain block. It's as simple as that. Now, you can read this 6 different ways to Sunday on how you can bill it, but I will tell you the carrier's point of view is that managing pain for a surgical procedure is inherent to the surgical procedure. That is how it's looked at. It doesn't mean it's wrong for a different doc to bill it. It doesn't mean it's wrong for a different procedure, okay? But here it is. It's controversial, and this is it, and this is what you have to go by. So whether or not you bill for it is a personal decision, business decision, whatever you want to call it. And I'll leave it at that. That one's a hot one. But there it is. That's Medicare's policy on pain blocks. Next slide, please. Here's another hot. We thought we would end the slide presentation with a couple of controversial coding issues, and so we did the pain block, and here's conscious sedation. The rules have changed, right, Tamara?
Yes. As of 2011, the CPT put a little blurb in the very front of the book talking about time-based codes, which one is moderate or conscious sedation. And so what it is when you are reporting conscious sedation, you will notice on 99144 that it says intra-service time of the first 30 minutes. And if you look in your CPT book, you have the definition of intra-service time, that it actually starts with the administration of the sedation agent. It requires continuous face-to-face attendance and ends at the conclusion of personal contact by the physician providing the sedation. And so in CPT for 2011, they clarified in fall of 2011 with a CPT assistant that conscious sedation for the first 30 minutes must span at least 16 minutes to be billed. So even though the definition of 99144 says for the first 30 minutes, you have to have at least 16 minutes of conscious sedation in order to bill that out.
The docs do not like this. Right, Tamara?
Right. We have the doctors complaining now that, oh, well, they could give conscious sedation starting in pre-op or something like that.
Maybe
but
parking lot.
Right. And, you know, I don't know how you can document it doing it in pre-op because you're not going to have the right equipment to monitor. And really, if you're giving conscious sedation, I don't see how you could walk down to the procedure room or the OR to have your procedure performed. So this has been a real stickler with our physicians.
And Kathy, we have one more. I'm sorry. A couple more. Okay, I'm sorry. Go ahead, Tamara.
Next slide, please. Another one we see over and over again from a coding perspective that causes a lot of discussion is what's called the Topaz grid procedure. And this is a procedure we see performed quite regularly for plantar fasciitis in the foot and epicondylitis in the elbow. And we've seen it where several of the carriers will say there's not a specific CPT code, and so it defaults to an unlisted. And we agree with that in our office as well, because if you really research and look what this Topaz grid procedure entails and how it's performed, there is not a specific CPT code that matches what the physicians are performing. And I know there's a CPT assistant that posed a question about, you know, what's the appropriate code to use when using a Topaz device. Well, it goes on to say that Topaz microdebrider is a tool, and so you're not coding for the tool, but you're coding for the actual definitive procedure. And if you do have a procedure that they're performing with this tool and it's a specific CPT code, then you're fine to use that code. But in the case of this Topaz grid procedure, this will default to unlisted, whether it's performed in the foot, whether it's in the knee or the elbow, because there is not a definitive CPT code that matches up with this type of procedure. Next slide.
The next one, if you code podiatry, you've probably seen the arthrodesis versus arthroereisis. The procedures sound very similar, but they are very different. The arthrodesis of the subtalar joint has a code, it's 28725, and it involves fusing a joint due to instability. So you'll see screws and wires being used to fuse the joint. The arthroereisis is unlisted, or they actually have a temporary code, S2117, so you'll want to find out what your carrier would like to see. But that is simply placing an implant in the joint to reposition and stabilize the rear foot. Although they sound similar, they are very different, and don't let your surgeons talk you into billing the 28725 for the arthroereisis. Next slide, please. And this is new for 2012, 29826, the arthroscopic subacromial decompression has been around for a while, but for 2012 it has now become an add-on code. And it is an add-on code to these other arthroscopic procedures we have listed, 29806 through 29825, 29827, and 29828. Well, this raised a lot of questions. What do you do if the only procedure they're performing is a subacromial decompression? If it's an add-on code, you can't report it with another code if they're not doing something else. So AMA and AAOS have recently stated that this should be reported with the debridement code 29822 or 29823. The same applies if they're doing an open rotator cuff repair, a 23410 or 23412. In addition to the subacromial decompression, you would bill a 29822 or a 29823 for debridement.
And, okay. Kathy, we're ready to take questions.
Okay. Thank you, Lisa, Jessica, and Tamara for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program, and as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. And we do have a lot of questions here, so I'm just going to dive right into the first one. This attendee asks, we are having difficulty in 2012 with the coding of peripheral nerve stimulator trials and implants and the use and acceptance of T codes.
Yes, they came out with the new T codes for a peripheral subcutaneous field in 2012. And Medicare does reimburse on the ASC side for those T codes. What we're seeing as far as on the pro side is that it's a carrier price code. I don't really believe that Medicare is really going to reimburse the physician very much on that procedure, but they are reimbursing on the ASC side, you know, pretty much like they do their regular stimulator codes.
Okay, next question.
Okay, this attendee asks, can you select a DX code from a previous visit, such as low back pain for a, and I'm going to butcher this, it's FESS, even if not actually noted on the OP note?
We're going to reread that. Could you pull that question up, please? We're going to reread that question. There it is. One moment, please, while we find it so we can read it.
It's TFESI.
Is it? Okay. Go ahead. Just general.
For the question regarding the 724.2 from a past visit, we would really like the documentation to be for the current visit. You know, they really should be documenting what is the chief complaint for the current visit. We would not recommend going to a prior visit. It really should be stated for that current visit.
Okay, next question.
Okay, thank you. Okay. Having problems with facet joint, physician is insisting that he is doing 3 levels. Can you discuss facet joint injections, please?
The problem may be in the documentation. We see that a lot. You know, some physicians prefer to document it as paravertebral nerves versus the actual facet joint. Each facet joint is innervated by 2 nerves, one above and one below. So if he's documenting it per level, you want to make sure that his description of the procedure has him actually injecting each facet joint level. If he's documenting it per nerve, you can only report it as per joint level. So it may just be a question of his documentation, but once again, his documentation needs to be accurate as to the procedure he's performing and the number of levels. But facet injections are only reported per level.
Okay, next question.
Okay, thank you. When a physician dictates incorrectly, like forgetting to say he or she snared a polyp, but a pathology report shows that he or she did, what is the preferred way to get that information? I have asked for an addendum to op reports, but have also had physicians dictate a whole new report.
I think, you know, that if you want to start using like an MD query form would be very simple. I mean, you can put the question out for him and he can just check it off. You don't necessarily want to go by the path because you're not sure that they're always getting the accurate information either. So I would definitely go back to him and clarify, but to make it the most simplest on him is to do an MD query, list out the question, and have him check it off and sign it.
Okay, next question, thank you.
Okay, thank you. When clarifying colonoscopies with the indication of rectal bleeding screening, doesn't the physician need to amend the documentation?
He can do that, or again, I mean, an MD query should suffice as long as, you know, you're asking the direct question and getting the question answered. That becomes a part of the medical record, so it should be enough.
Okay, thank you.
Okay, SI joint ablation, is that 64640?
Yes, that would be the correct code for an SI joint ablation.
Next question.
If the surgeon orders a pain block post-op and the anesthesia doctor does the pain block, can the facility bill or does the anesthesia doctor bill?
Okay, I would recommend that the anesthesia doc bill it. It's difficult for facilities to get paid for those types of procedures, so I would recommend the pro side bill it.
Okay.
Next question.
If a skin lesion is removed, like a cyst, and they close the subcutaneous tissue with Vicryl and then also close the skin, is that a simple repair or an intermediate repair?
The AMA guidelines, the CPT assistant states that in order for you to do an intermediate repair, they have to document deep subcutaneous tissue or deeper layers in addition to the skin or the more superficial layers. So based on this, I would do simple, or if you're seeing, you know, in his procedure heading that he's calling it an intermediate repair, I would go back to him and ask him for additional information if it is the deep subcutaneous tissue.
Okay, next question.
Okay, we have time for just a couple more questions. What specific documentation is required to determine the debridement code selection that would replace 29826?
That is a question that is still out there with AMA and AOS, and they will tell you that it still leaves room for doubt. I don't know how you could have a 29823 when we're just talking about debridement on one structure. So I'm thinking most scenarios you're going to see it's going to be a 29822. If you're doing debridement on another structure, such as you know, rotator cuff, then you're going to be billing the 29822 for the rotator cuff, and then you're allowed to use the 29826 for your add-on code.
Okay, thank you. This is a long question. How would you code for balloon sinuplasty for an Anthem patient when Anthem denies this as experimental? Can I bill 31256-31288 instead of the 31295-31297 codes, seeing they are opening the sinus cavity? Aren't these the same but just a different technique?
No, actually, if they're just performing the balloon sinuplasty, you have to go with the 31295 through 31297, I believe, codes. The only time you can actually code for the 31256 through 31288, I believe you said, is if they're actually going in and opening up the actual sinus cavity endoscopically, and then you can also report the codes that go with the tissue removal if they're actually removing the appropriate tissue. But the balloon sinuplasty codes would then bundle with those codes. But if they're just strictly doing the balloon sinuplasty to open up the sinus and they're not doing anything else, then you would have to use the balloon sinuplasty code.
Okay, thank you. Last question. Are implants such as L8699, C1713, or Rev Code 278 separately payable with surgical procedures in ASCs?
Okay, yes and no. Yes, they are, unless your contract specifically says they're not. So that's easy. Yes, you should build them out. But I will add this. I would always recommend attaching your invoice. What a lot of carriers will do when they adjudicate claims, if you're billing them electronically, the implant that is they will use their own internal fee max, which is lower than probably what you paid for the implant. So make sure, in order to get your implant cost plus, that you include a copy of the invoice to show what you paid for the implant, unless you're contracted and you know what you're supposed to get.
Okay, thank you. I want to thank our presenters again today for their excellent presentation and for all of you who participated today. We look forward to having you join us for future webinars, and this will conclude today's program. I hope everyone has a wonderful afternoon. Thank you.
Thank you, Kathy.